1800s, morphine and codeine were actually promoted, okay, even into the early 20th century. Patent medicines contained opium extracts, if you will. And they were promoted as something that was wonderful because people that were in pain or had all these problems were suddenly feeling pretty good. Okay? But in about 1920, it became unlawful to use these drugs, narcotics, in a way that was not regulated. And that's about the time that, because it was now illegal, people started using extracts and injecting them. And that's about the time that it started happening in this country. Narcotics are derived from the Greek word that means stupor, because they put people into a stupor. And when we talk about opioids or opiates, okay, we're talking about, when we talk about opiates, we're talking about substances that are actually taken from the poppy plant itself. But when we talk about opioids, we're talking about synthetic drugs that are similar in effect to the opiates that are made from the poppies, if you will. And the reason that they are related is because the receptors in our bodies, okay, respond to them in a similar way. So you're going to see this with drugs. When we talk about that drug receptor interaction, our bodies have to have something that is receptive to them in order for them to work on us. And often it's because they're going to be similar to something that's in our body. Remember we talked about epinephrine, right? Right? We have actually receptors that are responsible for having that kind of effect on us. So when you inject epinephrine, it will have that effect. They're classified different ways. So they're going to classify by the way that they work, their mechanism of action, okay, and on the different receptor sites. So they can be agonists that work the same way as the body, right? Mixed opioids, which can be agonist, antagonist, and pure antagonists, okay? They're also classified by their pharmacologic effect on the certain types of receptors. And they're also classified, this is the most common, as to whether they're weak, they're intermediate, or they're strong, okay? And they would be selected for, you always want to select the lowest dose that you need or the lowest amount that you need for the procedure or the problem that's happening. The strongest ones, and the ones in red are the drugs to know, okay? So I will post this with the colors so you know which one is the drug to know, okay? The strongest includes morphine. And anytime you talk about a drug, a strong drug, you're going to compare it to morphine. Morphine is the prototype, right? In that same group is methadone, meperidine, which we've already talked about as well, and hydromorphone. Intermediate are things like oxycodone, which is actually used in dentistry, and tazocine. Weakest, and again, these are also used in dentistry, hydrocodone, and things like Vicodin, Lortab, you've probably heard of those drugs, and codeine. Some codeine is in low doses is actually in over-the-counter things like cough syrups and whatnot. So those are the drugs to know. The mechanism of action is that the opioids will bind to receptors in both the CNS and the spinal cord, and it talks about the perception of reaction to pain, okay? It alters this. So do we actually have the pain and then we don't perceive that we have it? If it's mediated in the central nervous system, we have less of a reaction to pain, okay? Receptors, the different receptors on different binding sites. Remember, on any given tissue, you have different types of receptors, okay? They will determine, okay, they will mediate the specific pharmacological effects that it has, and also the adverse reactions of the different drugs. Now, the way that we know that these work, okay, is because we learn how our body normally works. And we have certain opioid-like substances in our body, believe it or not. And we've probably heard of these. Enkephalins, endorphins, heard that word, right? Dynorphins, I don't know that doesn't have a bullet, okay? These are neurotransmitter-like chemicals that are in our bodies normally. And when we study how our body responds to our own chemicals, we then know how the opioids work on us, okay? Our own body chemicals we have an addiction to. Have you ever heard about someone saying they are addicted to running or they're addicted to exercise? And when you're being really good and you're exercising all the time and you have that day when you can't exercise, you actually feel like you're missing something? There's actually a physiological reason for that. It's wild stuff. Do you ever like work out and then feel great? Okay, those are endorphins, okay? Those are our body's own drugs. okay? So work out, don't take drugs, right? You've heard those silly things, but I mean, it's true. Those are our body's own drugs. And the addiction potential that they have for an individual person, okay, may account for a person's individual tolerance to pain. So understanding how that works, those receptors work within our body with our own neurotransmitter-like chemicals, helps us to understand why people respond differently to pain as well. The opioid receptors, and there are a bunch of different receptors in our body, but the opioid receptors that they've done significant research are those called the mu, which look kind of like an MU together, the mu, the kappa, and the delta, okay? In naloxone, which we've heard of Narcan, right? We've talked about this already, the antagonist, okay, is an antagonist for all three of those receptor sites, and it's why it's so effective in actually backing up the effect of the opioids that they have in the body. It can actually take a potentially fatal situation and turn it around, including the respiratory depression that happens from the opioids, okay? So that's why Narcan is used for overdose treatment. It's extremely, extremely effective because it has an effect on all three of those sites. Okay. Receptor, and the book, actually the book doesn't, this is the old book that had this, but it's showing you that these receptors that are here on the cell are actually mu kappa receptors, and you see how they show them with different shaped receptors, and you can see here that the agonist fits them perfectly, okay? The agonist opioid, the opioid antagonist doesn't fit them, it just blocks them, okay? And then you have a mixed one that blocks one type of receptor and is an agonist for the other type of receptor, so it actually can maybe work on the pain receptor, but not work on the receptor that causes you to stop breathing. Okay, so there are actually mixed ones as well. It's extremely complex, but understanding the receptors helps us to understand why they don't all work the same way and don't all have the same adverse effects. Different drugs target different receptors purposefully. And this is the one from your book. And it's showing you the variation, okay, of the affinity of opiates, meaning if you have an affinity for the site, that's the site you want to go to, okay? So if you're driving this little car and there's that little teeny parking space, you can fit in there, okay? But if I'm driving a Cadillac, okay, I'm not going to fit into that receptor site, okay? So they have an affinity for certain receptor sites, okay? And so that shows the differences between how they work and how they adversely affect us. And you can see here, you've got the morphine opioid agonist here on your mu-K receptor. You've got the agonist antagonist site where you see one's blue and one's yellow. It's showing you that it has different effects on the same receptor depending on whether it's mu or kappa. And then you have here an antagonist that just blocks all of the sites. It's just showing you there's a difference. It doesn't actually look like that in our body. They're trying to give you a mental picture of the different ways that they fit or don't fit. We think that the different receptors have different physiological effects. So the mu receptor that we talked about is the one that we think is responsible for pain, okay? For producing analgesia against pain. The kappa receptor is also analgesia, that can cause dysphoria. You know what dysphoria is? That kind of otherworldly feeling. Okay, it's sometimes the feeling that people want when they take a drug. With the delta receptors, also for analgesia, but it's the one responsible for sedation, meiosis, which is what? That's one of the other spellings of the word meiosis.
Pupil constriction.
Constriction of the pupils, and diuresis, which is what? Voiding, okay? Yes, so the release of liquids, okay? There are new receptor types being identified. You don't need to know all of these. The sigma, the epsilon, they all have these Greek names, okay? But the reason that they're looking into all of these is to know how to make other drugs, okay? So we can separate the beneficial and the adverse effects. And drugs that target the beneficial effect but not the adverse effect, okay? The result of this will be more what types of drugs? More selective drugs, okay? The more we understand, the more we can make the drug selective so we get the benefit and not the adverse effect, right? Pharmacokinetics of the opioids in general. Most of them are absorbable orally. There are differences with some of them, okay? And absorption can also happen through the lungs. We actually know that the Narcan is a nasal spray, right? But I think that actually goes through the blood vessels in the nasal cavity, okay? From the nasal mucosa, the oral mucosa, and some actually can go right through intact skin. They have variable first pass effects, okay? What's a first pass effect? So you take the drug and what happens? The liver metabolizes it and it inactivates it, right? So it does that to some extent with all drugs, but if it has a high first pass effect, taking it oral is not a good idea, morphine being one of the examples of that. So the dose form is going to be varied depending on the variable first pass effect it has, whether it's high or whether it's low. Remember, morphine, only 25% of it is going to start being able to be distributed to the body because it gets inactivated by our liver very quickly. But 75% of codeine gets through the liver and is able to have an effect on our body. That's good. We do know that opioids cross the placental barrier, and respiratory depression can happen in the fetus if the mother is near term. So opioids are not a good idea, so you don't do that by choice. And we also know that there are children born with problems because of mothers that are addicted to opioids. The metabolism, okay, happens mostly in the liver. And the typical duration of action of an opioid is about 4 to 6 hours. It's excreted by kidney filtration, which is actually pretty typical. And both metabolites, which means what our body changes them into, or pure drugs can be eliminated in the urine, and that's why they can do urine testing for some drugs. Most opioids, because of their mechanism or duration of action, are then dosed every 4 to 6 hours because of how long they work on the body. Okay. So oral bioavailability of opioids is primarily limited by, think for a second, oral bioavailability, which is the way that we prescribe it. First pass effect, right? Good, you got that. Okay, pharmacological effects. Generally speaking, the stronger opioids are going to have the most adverse effects, okay? So we say the severity of the side effects is proportional to the efficacy or strength, okay? The desire for people that are addicted to opioids is generally for the strongest, and the strongest ones are the most addictive, okay? All goes together. They cause analgesia, they raise the pain threshold, okay, because they work on the CNS, right? They cause sedation and euphoria, so they have this other side effect of reducing anxiety, because if they make people feel a little bit sleepy and a little bit euphoric, which is what the drug addict actually craves, okay, they also relieve that. But if you're giving it to someone therapeutically, okay, it will help them with their pain, but it also might help them with their anxiety as well. We know that the opiates can depress the cough center in the brain, so they're used for cough suppression. We know about even codeine, even weak ones work very well. And the GI effects, if they increase the smooth muscle tone, okay, and they're always saying that it increases tone makes you think it makes it work better, okay, but if you increase tone, you reduce motility, okay, and they decrease propulsive contractions of the GI tract, so they constipate people, okay? Big issue with these. Okay, pharmacologically, we know the morphine is the prototype strongest one, and hydrocodone and codeine are down around here somewhere. So for most dental procedures, we're talking about the lower or the weaker ones, although sometimes we go up to something like oxycodone. Adverse reactions are an extension of their pharmacologic effect. So they're not doing something weird someplace else. They're generally an extension of the pharmacologic effect that they have on the body that we just discussed, okay? So these are different from a lot of the other drugs that primarily adverse effects are going to be on things like the kidney and the liver, okay? These are more because of the same action that they have. They're extensions of the pharmacologic effect that we're desiring, okay? Respiratory depression is huge, okay? That's usually the cause of death with an overdose is by respiratory depression, and the Narcan actually reverses respiratory depression. That's one of the reasons why it works. Nausea and emesis, so nausea and vomiting, is a result of direct stimulation of the chemotrigger receptor zone in the brain, okay, in the medulla. Constipation is because of the contraction of the tonic contraction of the GI tract. It stiffens it up and keeps it from moving food through. Pinpoint pupils, okay, and urinary retention, okay, because it doesn't cause the kidneys, excuse me, what is that called for your bladder to contract. I couldn't think of that other thing. It doesn't cause your bladder to contract, and it causes urinary retention. Okay, this is a thing now. Have you seen the ads for opioid-induced constipation? Let's find some other drugs. Instead, we give another drug. But you have to think about people that are in chronic pain, especially people that have chronic non-cancer pain, chronic cancer pain. They're using opioids a lot longer and a lot stronger, okay? And it's really a huge problem that this opioid-induced constipation happens, okay? So there are actually, this is not in your book. There are actually several medications that are now given for this that I wanted to list for you here because you may have patients that are taking them. Lexegol is one of them, methylnaltrexone, and these are two of the most common ones, and they actually work on the receptors to get things going. The adverse effects that they can have, of course, would be GI pain and diarrhea because you're trying to reverse this, and they can actually stimulate opioid withdrawal symptoms because they're working in an antagonistic way, right, on the opioids effects that they're having. But I did want you to know that these are something out there, and you may see patients that are taking them. Central nervous